this essay, how to write the essay about the thyroid gland. First, when you write the essay about the thyroid gland, the following subheadings to be written. First is the extent, from where to where it extends. Second is the relation parts, and the third one is the relations for each part, and then fourth one is the capsule, and fifth one is the blood supply, and sixth one is the lymphatic drainage, and the seventh one is the nerve supply, and eighth one is the clinical application. So in these subheadings only you have to complete the essay of thyroid. So first, for that we need to draw a diagram. So what is the diagram? With this diagram only I could explain everything. Here itself I will draw the diagram. The number one is, first we should draw the thyroid gland. This is the butterfly shaped gland. So we have to draw like this. Look at this, the base, and here is the base. Understood? So like this I have drawn. Understood? This is the apex of the thyroid gland, and this is your cartilage. Thyroid cartilage is here. This is your Adam's apple. This is the apex of the thyroid gland. So this one is the apex, and this is the base, and the middle one is the isthmus of the thyroid gland. Before going into this thyroid gland proper, a small embryology for your understanding purpose. Small embryology is, initially you will be having a foramen. There is a area called foramen cecum. Here all the endodermal cells, they come and they accumulate and they transform into the tongue. Understood? This is tongue. And from the foramen cecum, the endodermal cells, they invaginate and then go down into the neck, and they form this gland. This is your thyroid gland. So this is the area through that endodermal cells are coming down. That is the area through that pathway, that is called as thyroglossal duct. So after the formation of the gland proper, this thyroglossal duct has to be obliterated. If it fails to obliterate, sometimes this only the caudal portion of the duct will be remaining, and it will be continued along with the isthmus, that is called as pyramidal lobe of the thyroid. Sometimes from the pyramidal lobe, the cranial portion will be attached to the hyoid bone. But in some cases, the thyroglossal duct, in some places, it is not obliterated, and it not gets obliterated, and that part of the area, there will be a collection of fluid in that area that will be transformed into thyroglossal cyst. Usually it will be obliterated. If it fails to obliterate, that area alone will be transformed into thyroglossal cyst. But this duct is already, it is connected with the tongue. So what happens when you protrude the tongue? This thyroglossal cyst will be moving up and down, but not the thyroid gland, because this entire area is obliterated. Only the unobliterated portion only you will be having the thyroglossal cyst. But this area is connected with the foramen cecum, which will be developed into the tongue. That's why whenever you protrude the tongue, this thyroglossal cyst will be moving up and down, but not the thyroid gland. Understood? This is a very important clinical aspect we will see later on. So this is about the thyroid gland. From the foramen cecum only, the cells will be going down, and they will be forming via the duct, it will be forming the thyroid gland. After the formation of the thyroid gland, it will be obliterated, right? Now we will go to the subject proper. This line in the thyroid cartilage is called as oblique line. Understood? So this is your Adam's apple, and this line is called oblique line. So this is the upper limit of the thyroid gland. So the extent of the thyroid gland, when you write, you should write both the vertebral level as well as the anterior level. So vertebral level, how will you write? It extends from C5 vertebra to T1 vertebra, thoracic 1 vertebra. Otherwise, you can write like oblique line of thyroid cartilage to the C5 tracheal ring. Okay, sorry, fifth tracheal ring. Okay, it is called as fifth tracheal ring. Like that you should write fifth tracheal ring. So here inside you will be having the trachea, right? So here we will be having the tracheal rings. So this is the first tracheal ring. So here we should draw the first tracheal ring. This is the second, third and fourth tracheal rings will be here. So we can draw the tracheal rings like this. Okay, second, third, fourth tracheal ring. Here this is the fifth tracheal ring. This is the fifth tracheal ring. Understood? So the extent, how will you write? C5 to T1 or from the oblique line of the thyroid cartilage to fifth tracheal ring. Understood? This is the apex and this is the base. And then this, what about the lobes? So parts, when you write, you have the two lateral lobes and one in the middle isthmus. So we have to write the relations separately for the lateral lobe as well as for the isthmus. So for the lateral lobe, what are the relations you will write? First we should write one important muscle, strap muscle, anterior relations. Anterior relation, what is the strap muscle going here? So that is the one which is going from here to here, that is to the hyoid bone, that is called as, so you have to draw the hyoid bone here. So this is the sternum, from the sternum, okay, from the sternum it is going here, so sternohyoid. Okay, beneath that you will be having the next muscle, sterno, again this is sternohyoid, so we can use some other color, that is your sternothyroid. Understood? Sternothyroid. Look at this, where that sternothyroid is going. So the sternothyroid is going to the oblique line of the thyroid cartilage. I said the lateral lobe is also attached to the oblique line. So what happens? This sternothyroid attachment to the oblique line prevents the enlargement of the thyroid gland towards the superior border. So it cannot extend beyond this. So it may extend down and enters into the superior mediastinum, but it cannot extend into the upper part because of the attachment of the sternothyroid to the and the lateral lobe to the oblique line of the thyroid cartilage. This is a very important clinical application. You should not forget to write. So anteriorly you have to write sternohyoid, sternothyroid, and one more muscle on the side. Everybody knows that, that is your sternocleidomastoid. Sternocleidomastoid. You have to write sternocleidomastoid. So these are the three muscles anteriorly or anterolaterally you can write. Next muscle is, what are the next structure is, what are the structures lying medial? Medially, what are the structures are there? What is this cartilage? Thyroid cartilage. So what could be the next cartilage? An empty space is here. We need to fill up the empty space. That is your cricoid cartilage. What is the cartilage? Cricoid cartilage. So you have to draw the cricoid cartilage here. That is a ring shaped cartilage. So I have drawn like this. Okay, this is the cricoid cartilage. So cricoid cartilage, so medially you have two tubes, two muscles and two nerves. Two tubes, what are the two tubes? Number one is the trachea, everybody knows. That behind the trachea you will be having the esophagus. So two tubes, you know, two tubes. So when you write the relations, you have to write relations for the lobes and relations for the isthmus. So isthmus and the lobe. So for the lobe, what will you write? Anterolateral or superficial relation, sternohyoid, sternothyroid, sternocleidomastoid. And then medial, posteromedial relations, actually medial relations. Medial relations you have to write two tubes, trachea and esophagus, and two muscles. What are the two muscles you will write? One for the trachea and one for the esophagus. You have to write two muscles. The trachea muscle, see, look at this, larynx. Here cricoid cartilage is there, this is the thyroid cartilage. So which muscle connects the cricoid to thyroid? That is your cricothyroid. So here you have a muscle by the name cricothyroid. So this is the cricothyroid. So this is also medially placed, cricothyroid. Next to the cricothyroid, if you see this aspect of from the cricoid to pharynx, you have a muscle. From the thyroid to pharynx also you have a muscle. That is called cricopharyngeus and thyropharyngeus. Together it is called as inferior constrictor. So two muscles we have drawn here. One is cricothyroid, another one is inferior constrictor of the pharynx. So two muscles I have drawn here. So what are the two muscles? One is for the esophagus is inferior constrictor, and another one for the trachea is, and then larynx is cricothyroid. Okay, two muscles we have seen. So nerves also, two nerves. So two nerves, how will you write two nerves? One is for the cricothyroid, that nerve is called external laryngeal nerve, and the other one is called as recurrent laryngeal nerve. So how will you draw the nerves? I will use this orange color. Yellow color only you are supposed to use. So here you have to draw the nerves. So how will you draw the nerves? First is medial relation only. So the first one, external laryngeal nerve supplies the cricothyroid. So that will be coming here. And the recurrent laryngeal nerve will be coming here to the inferior aspect. So here you have to draw the recurrent laryngeal. So both the nerves, external laryngeal and recurrent laryngeal nerves. Recurrent laryngeal is a branch from the vagus. So next we have to write the posteromedial relation, posterolateral relationship. What lies posterolaterally? Posterolaterally only your carotid sheath is present. So carotid sheath contains what? Carotid sheath posterolateral. This is the behind. So posterolaterally you have the vein. Which vein? Internal jugular vein. And which artery? Common carotid artery. Common carotid artery you have to draw, and then in between you have the nice nerve, vagus nerve, right? Vagus nerve. This is the which sheath? Carotid sheath. So vagus nerve, when it comes, it winds around the subclavian artery, and then it comes here as which nerve? Recurrent laryngeal nerve. So don't forget, at the same thing, vagus nerve goes here and supplies, gives a branch external laryngeal nerve. So both are coming from vagus. So this forms the posterolateral relations. So posterolaterally you have to write. So this anterior you have the muscles, and medial you have two such structures, and posterolaterally you have the carotid sheath. Carotid sheath contains, everybody knows, internal jugular vein, common carotid artery. In between you will be having the vagus nerve, right? This is the posterolateral relation, carotid sheath. So finished. So lobes relations you have finished, and then isthmus relations you have to make. So isthmus relations anteriorly, again the same, strap muscles, and posteriorly which tracheal rings I have drawn? Second, third, fourth tracheal rings. This structure is very important, because when you want to do something called as tracheostomy, making an opening in the trachea, you have to incise this. If it is an elective condition, slowly if you want to do this, you can slowly dissect all the strap muscles what is present in the front. So in the front, what are the muscles? Already we know the same sternohyoid, sternothorax only, midline. So we have to cut all those muscles, and then you have to take the tracheal rings, and then through that only you can put the tracheostomy tube. So you have to cut the isthmus, you have to dissect the isthmus, then only you can enter into. So this relation is very important. Second, third, fourth tracheal rings are very important. Already I said base is related to fifth tracheal ring, right? So this is second, third, fourth only. It is related to the posterior aspect of the isthmus. Second, third and fourth. So it is very important. So relations, when you talk about the relations, you have to be very careful. And surfaces we have finished. Now the most important, border. Okay, so this is the anterior border and this is the posterior border. So again I will draw. So we have to draw the apex, and then both the sides lobes, and then here you have the isthmus. Understand, this is the anterior border. So what lies in the anterior border? So anterior border, already which artery is coming? Carotid artery is here, and the branch of the carotid is here, external carotid. The first branch from the external carotid is your thyroid. So the thyroid will be coming here, and then thyroid and anterior branch, descending branch will be coming via here. So this side also you will be having the same external carotid artery. The first branch thyroid will be coming here, and the descending branch will be coming from here. So the thyroid artery, both the sides, they come along the anterior border, and along the isthmus it forms an anastomosis, right? This along the isthmus it forms an anastomosis. And then here you will be having the subclavian artery. From the subclavian artery you have a trunk called thyrocervical trunk. From the thyrocervical trunk you have an artery called as, this is your inferior thyroid artery. Okay, so this is your inferior thyroid artery. So here also you will be having the subclavian. The subclavian you have the thyrocervical trunk. From the thyrocervical trunk you have an artery called as inferior thyroid artery, right? Inferior thyroid artery. So this is inferior thyroid. So here in the upper pole you have the superior thyroid, here in the lower pole you have the inferior thyroid, and along the posterior border this inferior thyroid artery's ascending branch will go and they form an anastomosis with the branch from the superior thyroid. Understood? This is along the posterior border. Another one most important relation is along the posterior border you have a very important gland situated, that is your superior and inferior parathyroid glands. So that is more important, superior and inferior parathyroid glands. So when you write the anterior border is very sharp, and the branch from the superior thyroid artery is lying over there, and the posterior border you have the inferior thyroid arteries coming up to form an anastomosis. Along with that you have the parathyroids. This is about the borders. What about this border? Along the superior border of the isthmus, you have an anastomosis of an superior thyroid, both sides superior thyroid. Along the inferior border, you should not forget to write about the vein called inferior thyroid vein. So you have to write about the inferior thyroid vein. This inferior thyroid vein will be draining into a big vein called brachiocephalic vein. What is the vein lying here? That is your internal jugular vein. And then what is the nerve lying between these two? You have the vagus nerve. So what is the branch of the vagus nerve? That is your recurrent laryngeal nerve. Recurrent laryngeal nerve winds around which artery? Subclavian artery. So it winds around and it comes here, and near the pore both are together. Can you see? And here also I have to draw the external laryngeal nerve. External laryngeal nerve, okay, near the origin. External laryngeal is coming here, and then what happens? External laryngeal will go here, and it will go here and supply the cricothyroid. Okay, so it has to go medially. So it has to go here and supply the cricothyroid. So when near the origin, see, artery is coming and the nerve is going out. Now the near the pole, the nerve is going out. It is not near the artery. See, look at the gap. So the artery is here. Okay, artery is here. It is coming here, and the nerve is going away. So this is the near the pole. So this is how you have to draw the recurrent laryngeal nerve and the external laryngeal nerve. So you know the borders. Superior border of the isthmus, you have this, and the most important one along the superior border is you have to draw one important lobe. In some people, 30% of the cases, I can say that you nicely one lobe, that is called as pyramidal lobe of the thyroid gland. I can draw pyramidal lobe. From the pyramidal lobe, sometimes few fibers will be going up. That fibromuscular band, it is going up, and it is attached with the hyoid bone. So that is called as, this is pyramidal lobe of the thyroid gland, and this is the levator glandulae thyroidae. Understood? Levator glandulae thyroidae, which is going and get its attachment with the. These are all the remnants of what? Thyroglossal duct. So right. So this all you have to write for the isthmus. So isthmus anteriorly you have sternohyoid, sternothyroid muscles, and posteriorly you have the second, third, fourth tracheal rings, and then along the superior border you will be having the pyramidal lobe and levator glandulae thyroidae in some patients. For other patients you will be having the anastomosis. Along the inferior border you will be having the inferior thyroid vein. These are the relations. Now I will be going to the capsule. When you write about the capsule of the thyroid gland has its own capsule, true capsule and the false capsule. So true capsule, you have to write only one word, own condensation. The tissue's own condensation, they form the true capsule. False capsule is derived from the pretracheal layer. So pretracheal layer is nothing but the from the deep cervical fascia. This layer in front of the trachea, the deep cervical fascia, is named as pretracheal layer. But one interesting thing is the pretracheal layer along the posteromedial aspect. When it comes here to the medial aspect of the thyroid gland, here it is seen clearly. This is your cricoid cartilage, this is your thyroid. So here to here, from the medial, posteromedial aspect of the thyroid gland to the cricoid cartilage, the thickening of the false capsule, that is your pretracheal layer, that is called as ligament of Berry. So when you want to dissect the thyroid gland, you have to cut this ligament of Berry, then only you can remove that. So this ligament of Berry's attachment is very important. This is the thickening of the pretracheal layer or false capsule. It is attached from the posteromedial aspect of the thyroid gland to the cricoid cartilage. That's why this thyroid gland is moving up and down with deglutition. So the clinical importance of the pretracheal layer is it is thickened on which part and forms the ligament of Berry. Along it is attached from the posteromedial aspect of the thyroid gland to the cricoid cartilage. Because of this attachment, thyroid gland moves up and down with deglutition, not with protrusion of the tongue. Protrusion of the tongue means thyroglossal cyst you have tried. So this relationship very important. And between the true capsule and the false capsule, what you have? You have the thyroid arteries are coming inside, the stem of the thyroid arteries are lying inside, and inside only you will be having the plexus. Okay, the plexus will be lying inside. So only the stem of the artery will be there. Along with that, you will be having the most important gland, parathyroid glands are situated here. So along between the true and false capsule only you will be having the parathyroid glands. So what is the clinical significance of that? The thyroid gland, when you remove the thyroid gland, the artery to be clamped, in this area where between the true capsule and the false capsule. This is the true capsule and this is the false capsule. True capsule is bone condensation. So inside the true capsule only it forms a plexus. So you want to clamp the artery means you have to clamp here only between the true and false capsule. So this is an important relationship between the true and false capsule. So the thyroid gland, the plexus should not be disturbed. So the thyroid gland to be removed along with the true capsule. Understood? So but in prostate you will be having the true capsule. For your understanding purpose I am telling this is the true capsule and the false capsule of the prostate, but here the venous plexus will be situated between the true and false capsule. So what happens? We cannot disturb the true capsule. So it has to be only the gland has to be enucleated. Understood? This is about the prostate and this is about the thyroid gland. Thyroid gland, the stem of the artery is lying between these two. So capsule over, gland over, and then last is the blood supply. Blood supply, how will you draw? Here already we have drawn that. Which artery supplies the upper pole? Superior thyroid artery is a branch of external carotid. There is a branch of external carotid, common carotid, and here the internal carotid will be going up. Okay. This is about the superior thyroid arteries coming here. Inferior thyroid, already I have told you, there is a branch from the thyrocervical trunk. So two arteries over. Sometimes you have an extra artery called arteriothyroidema that will be directly coming from the arch of aorta. Directly it will be coming from the arch of aorta. And what about the venous drainage? You have the very interesting venous drainage. You have superior thyroid vein draining into the interjugular. Middle thyroid vein also drains into the interjugular. But what about the inferior thyroid vein? Already I told you inferior thyroid vein drains into the brachiocephalic vein. Sometimes you have a Koch's vein, that the fourth vein, that will be draining into the internal jugular vein. So this is about the venous drainage. What is the clinical significance of this blood vessel and the arteries? So see, look at the inferior thyroid artery and the recurrent laryngeal nerve. They both are very close near the lower lobe. So what happens? Where will you clamp the artery? The artery to be clamped away. Then only you cannot. If you clamp here, the nerve is escaped. If you clamp here, what will happen? Both the nerve will be as well as while clamping the artery, the nerve will be injured. So inferior pole you have to clamp away. But what about the superior pole? Superior pole you have to clamp nearby. Look at the pole. Here only you can clamp. Otherwise, what will happen? See, near the pole, the nerve is away. It is going towards the cricothyroid. So it is going medially. So you have to clamp near. Superiors, always keep your superiors near and inferiors away. Like this you have to clamp. So this is about the clamping of the arteries and the surgical significance of the superior thyroid and inferior thyroid vessels and nerve. And then last is the nerve supply. Nerve supply you have to write about the sympathetic and the parasympathetic. And sympathetic you have to write sympathetic is you have the cervical ganglia, superior cervical ganglion, middle cervical ganglion, inferior cervical. According to the books, it is given as middle cervical ganglion only. It gives a branch to the thyroid gland. But in many people, the middle cervical ganglion won't be there. So you can write superior cervical ganglia as well as the inferior cervical ganglia. It arises now. Parasympathetic supply is from, I have already told you, the nerves, vagus mainly. Vagus branches are coming over here. So that is about the parasympathetic. What about the lymphatic drainage? Lymphatic drainage, you have the pretracheal and paratracheal group of nodes. Upper part, you have the laryngeal group of nodes. So to pretracheal, paratracheal, prelaryngeal, paralaryngeal group of nodes. They are ultimately draining into the cervical group of nodes. So this is about the lymphatics. And clinical application, number 1, we have to write a clinical anatomy and surgical applications only. First application is the superior limit of the thyroid. Thyroid gland cannot go superior, extend superiorly because of the attachment of the sterno. I will show you here. Because of the attachment of which muscle? Sternothyroid to the oblique line of thyroid cartilage. This is the clinical application number 1. Number 2 is the capsule. Capsule just now explained, the thyroid artery to be clamped between the true capsule and the false capsule, and the thyroid gland moves up and down with deglutition because of the attachment of ligament of Berry. The ligament of Berry is attached to the cricoid cartilage. Cricoid cartilage is forming the larynx. Larynx continues down as trachea. So what happens? Everything is interrelated. So whenever during swallowing, this gland moves up and down during the swallowing because of these attachments. So number 2, clinical aspect. Number 3, thyroid gland clamping. Number 4, this arteries, how you will not injure this arteries. And then number 5, thyroglossal cyst. Already I explained the thyroglossal cyst. Thyroglossal cyst. If there is some remnant of the thyroglossal duct in the pathway, that will be transformed into a cyst. Since the cyst is connected to the thyroid duct is connected to the foramen cecum and the tongue, it is during protrusion of the tongue only it moves up and down, but the thyroid gland moves up and down with swallowing. So that's all about the thyroid gland essay. So all the salient points we have covered. You should not forget any points while writing. Pyramidal lobe and levator glandular thyroid we have covered. Thank you.